Hit the subscribe button or visit us at auau.auanet.org.
Well, hello, everybody. Welcome to the course, Practical Implementation of Third-Line Therapies for Refractory Overactive Bladder. We're so pleased to have you here with us today, and we hope this will be a fun and informative course. It's my pleasure to introduce my esteemed faculty, my dear friends and colleagues, Dr. David Ginsberg from University of Southern California, where he runs the neurourology service there as the chief, as Dr. Sandip Vasavada from Cleveland Clinic, who heads up the FPMRS, or Female Pelvic Medicine and Reconstructive Surgery Service. And then for me, I'm from Virginia Mason in Seattle. These are our disclosures. So we're starting off with a pretest, and hopefully at the end of this, all of these questions will be simple at the end, but hopefully it's a little bit of a challenge from the outset. So pretest question number one, we're going to have a little poll. If you could please go ahead and participate. So a 77-year-old woman has urgency incontinence despite therapy with mirabegron at 50 milligrams PO daily for 6 weeks. She would like to proceed with a trial of posterior tibial nerve stimulation. According to the AUA SUFU OAB guidelines, and the choices are A, must first have at least a 2-month trial of oral medications. B, must first fail combination therapy, mirabegron and an anticholinergic. C, must first fail at least 2 oral medications for OAB. D, can proceed with PTNS, and E, cannot proceed with PTNS since she is greater than 75 years old. These will be the same questions you get in your post-test, so hopefully we make a difference. Okay, we'll go on to the next question. 2 weeks after injection of 100 units of onabotulinumtoxinA, a 54-year-old woman's OAB symptoms are greatly improved. PVR is 275 cc's. The next step is monitor symptoms, check urinalysis, prophylactic antibiotic therapy, tamsulosin 0.4 milligrams, or initiate daily CIC. Okay. Number 3, a 61-year-old woman with overactive bladder is undergoing posterior tibial nerve stimulation weekly. She's on her 4th week and feels minimal clinical benefit so far. Her urinalysis is negative and post-void residual is 65 cc's. The next step is continue PTNS weekly, increase amplitude of stimulation, change PTNS to contralateral tibial nerve, change to sacral neuromodulation, add onabotulinumtoxinA injections. Please go ahead and participate in the poll. It makes it more interactive and fun. Okay, during placement of a lead for sacral neuromodulation, bellows only is noted. The next step is go up one level, go down one level, try to go higher and more medially in the foramen, turn up the stimulation, ask the patient about their sensation. Did I do that prematurely? I may have. My apologies. Okay, last pretest question. CIC in patients following onabotulinumtoxinA injection is more frequently necessary in idiopathic OAB than neurogenic OAB, is implemented in 15 to 30% of neurogenic patients, should be instituted if PVR is greater than 250 cc's, is not associated with the dose administered. Okay. Well, let's get started here. I just want to tell you a little bit about the format of this course. And, we'll really be following the AUA SUFU OAB guidelines and concentrating primarily on the third line therapies. As you know, the guidelines have been updated. Now there's fourth line therapies and other therapies, but first and second line therapies, of course, include behavioral modification or behavioral therapy, dietary modification to avoid bladder irritants, physical therapy. Second line therapies are really pharmacotherapy. And when those things don't work for our patients, I kind of call that plan A, but first and second line therapies, there are advanced therapies. And we're going to focus primarily on the third line therapies for this course, that being onabotulinumtoxinA injection into the bladder, PTNS or posterior tibial nerve stimulation, and sacral neuromodulation. Now, of course, we were thinking this was going to be live, so we wanted it to be really interactive, and we're going to do our best to make that happen even virtually. So if you have any questions or thoughts, please go ahead and type them in there, and we'll do our best to kind of hit the balls as they come to us live. But we really wanted to make this sort of more interesting and practical. So we made it very case-based. And so we're going to give you a couple of cases, 4 cases to be specific, and we're going to discuss these third line therapies in the framework of these cases. So again, we want to encourage an interactive format. We also have a little, a few words that Dr. Vasavada will tell us and update us on what the future holds for us in treatment of overactive bladder. And then we'd like to have sort of an open discussion, again, virtually. The cases that we're going to frame our discussion on include a male and a female with refractory overactive bladder, a patient with dual incontinence, which is both urinary incontinence and what we call accidental bowel leakage these days, or fecal incontinence, and neurogenic bladder. And using those cases, we hope to really give you some good food for thought and some practical tips in a fun sort of way. Ultimately, our take homes are going to be, please be thinking about this as you're listening to all of our discussion here. Where and when do you actually introduce third line therapies into the algorithm for your patients? We want to give you some counseling tips, friendly language, things that are not intimidating to patients in the way we present the therapeutic options to them, so we don't turn them off for the wrong reason. We want to talk about if one third line therapy is better than another for a given patient, really optimizing some practical things like optimizing your clinic flow, your ASC flow, that sort of thing, really engaging and empowering your staff to be a part of the therapy for your patients. I think they really enjoy being an integral and important part of the team that is really making a difference for the patients. And that really makes this all work a lot better, and sort of minimizing the hassle factor in your office flow in that regard. We want to talk about a couple of little tips on things like optimizing lead placement and troubleshooting, that sort of thing. So really, we want to make this practical but interesting for you. So let's start with case number 1. It's a 54-year-old healthy woman with OAB. She's failed conservative measures and isn't really enthusiastic about medications, which we find a lot these days, certainly in the Pacific Northwest. So the question is, do you have to use medications? Do they have to go through medications? And, of course, we have to take into consideration, are the medications efficacious? Are the side effects worth whatever efficacy we get out of them? And then cost is always a huge factor here in the United States. And if you do medications, how many medications do you have to use before you go on to third line therapies? So with that, we're going to talk a little bit about counseling. I want you please to think about, what other information do you need about this lady? When do you introduce third line therapies? Do you have a typical scripting that you use to talk to patients about what their options are? And how would you choose in this patient? I think it's really important for us to think about something is scripting. So again, using friendly language so that the patients don't get intimidated by the therapy, the way you describe the therapy, and really goal setting, shared decision making, right? Really goal setting together with your patient so that you can align what we can do with our available therapies with what they are expecting to get out of it. So I think making that treatment plan together with your patient is very critical. So with that, I'm going to ask Sandy, when do you introduce third line therapies, and do you have a typical language that you use or way that you counsel your patients?
Yeah, I think that's a great question. And when we look at when to introduce this, as you can imagine, some of our subspecialty based practices, sometimes we get patients referred very specifically for third line therapies. But when we do have the opportunities to see patients, sort of naive to overactive bladder therapy, as Dr. Kabashi mentioned, we'll start with the first line management. But even in that first line discussions, I will say, listen, we have opportunities to go on to second line, which is adding medications. And then even if that doesn't work or we don't get optimal responses, we can even talk about other management schemes, including the posterior tibial nerve stimulation or Botox or sacral neuromodulation. So I think many of us now will introduce that really early and upfront. I necessarily will not go into any level of detail on any of those additional therapies, but at least say, mention the framework. As Dr. Kabashi mentioned, I think it's so much of a shared decision-making. And as we all know in medicine now, with these expectations coming in rather high for so many of our patients, if they come into that office and they want to walk out with a pill, and you really just keep harping on physical therapy and pelvic floor exercises and caffeine reduction, and they took one coffee a day, they're going to leave rather disappointed. So at least setting the stage to say, would you like a medication? I don't think it's wrong. And again, to say, do you want to consider additional therapies later on down the line? Should they be something that needs to be done? I think that's very fair.
Great. David, do you have anything to add to that insofar as your language, et cetera?
Yeah, I think what Sandip says is right on. The other thing is, I think we all will read our patient's body language to a certain degree. We may start talking about pelvic floor therapy and then be like, Doc, I know I'm not going to do that. Or you may mention medications. They're like, well, is there something that's more natural or something along those lines? So, what I tend to do is, like Sandip, I say, look, we can do non-pharmacologic options. We can try pharmacologic options. We can try both at the same time. And again, it's that shared decision making and see where the patient wants to run. And I think one of the most important things that we do is say, if you fail whatever we start first, we are going to have other options. Mm-hmm. So they know that if they don't have a good first response, we have other things to offer them. I think that's super important.
Yeah, so I introduce it really early. When I give them their first prescription, I tell them about third line therapies in sort of friendly language. So I'll tell you a little bit about it when I talk to you about the sacral neuromodulation, but I tell them the battery is like an Oreo cookie. And so things like that make it a little more friendly, and we'll talk about that in more detail. But I also introduced it early just because I don't want them to get discouraged, right? If you give them a prescription, say, come back in 6 weeks, or come back if it doesn't work, well, they're probably not going to come back if they don't know there's something worth coming back for. So I do give them a pretty good introduction at the beginning so that they know if plan A doesn't work, then we've got plan B, C, and D in no particular order. So, and we'll talk about that. Super. Okay. So David, is there any data or is there anything in the literature that actually helps you choose one over the other, or is it just more sort of feeling your patient out?
Well, I think it's yes. The answer to that is yes. I mean, the data, I use all the data. You use the data of, like what I said, the patient's body language. You're looking at the data on oral medications. And when you speak about how many medications are you going to use, there's certainly no evidence that, going to medication 3, 4, 5, and 6 are going to make a difference if medication 1 or 2 work. So I think the point being, I think most of us that do a lot of this don't take a long time to go from maybe a medication failure, whether it's because of side effects or lack of efficacy, to then going to a third line therapy. So absolutely. And there's, what is the data that I use when I make a decision? It's also my screen telling me how much the medication is going to cost. It's like, okay, this is red, so I'm not going to go with that medication. Or you live 100 miles away. So when we talk about third line therapies, maybe PTNS is not going to be good for you coming to see me once a week, 100 miles away. Or like you talk about dual incontinence and you have fecal incontinence, there may be different, not better options for that. So, data is super important, but it's including literature, but like patient data and insurance data, I think all plays a role as we put it all together and figure out where we're going.
Absolutely. I totally agree with that. That actually brings up another point I wanted to say about the guidelines, which Sandip knows very well because he was involved in this guidelines panel. But there is one caveat that's added to the revision, and that is that this is not an algorithm. You don't have to go, first line, second line before you go to third line. You could actually start with third line therapies. Now that I say that from a guideline standpoint, but the practical side of things is that many times insurance companies will require, regardless of whether we agree with it or not, that you have to try 2 medications before you can go on to a third line therapy. But the it's not an algorithm. So the guidelines explicitly state that you don't have to go through each step before you go to the next one. So, a lot of patients will come in and say, I'm not taking meds. Then, can you go on to third line therapies? And the answer is now, yes.
Right. So it's also interesting, I think, how often patients will come in because someone told them, or they have a friend, they come in and say, I want botulinumtoxin, I want tibial nerve, I want sacral neuromodulation, and they've tried nothing, and sometimes that works. That depends on their insurance, because sometimes the insurance will say, you have to fail, like you said, X, Y, and Z, but they may come in wanting one of those therapies right off the bat.
Right. So I think the point is to introduce third line therapies early so that they know that they exist and don't get discouraged if medications don't work. And I think it's really all in the presentation and the language that we use, so we don't intimidate our patients before we get a chance to really talk to them about some of these great therapies that we're going to be talking about. Okay, let's do a male patient. There are certain caveats about males. 62-year-old guy with OAB symptoms. He's got urgency with occasional close calls to urgency incontinence. His frequency is every hour and a half or so, but he's got nocturia 3 times every night. He's got very mild obstructive symptoms, so not really much to speak of. Post-void residuals 20 cc's. He tries mirabegron and fails it, and he declines antimuscarinics, which a lot of patients are these days with the new sort of link to dementia. So are there caveats for a male? I'm going to ask David to comment a little bit on counseling, how you choose, minimum workup before third line therapies, and then maybe we'll ask Sandeep about PTNS a little bit.
So I think the male patient can be more of a challenge for us, because obviously there's a prostate involved, and theoretically the prostate can be impacting the symptoms or potentially be the primary cause of their storage symptoms. You look at the guidelines, there's nothing in the guidelines that suggests we need to do more evaluation for a male patient. There's nothing in the guidelines that says you have to do urodynamics with the pressure flow to rule out bladder outlet obstruction. So I think a lot of it is getting that gestalt. Does that patient have primary storage symptoms? You think they have storage symptoms? There's really no reason to say, I need to do urodynamics and do a pressure flow study. You want to feel a little better and get a non-invasive uroflow, I will do that. And I think that also can be helpful, knowing that it's a screening tool and doesn't rule out or rule in bladder outlet obstruction. But I also have I have no problem with, if I'm not sure, I may do urodynamics before I'm going to go in and do certain therapies. If you look at the data I'm going to talk about later, there's always a concern about, for example, doing botulinumtoxin in a male patient with some degree of bladder outlet obstruction. Am I going to put him into retention? I would certainly not want to do neuromodulation in the setting of bladder outlet obstruction, thinking that we're not going to have as good an outcome because the obstruction is there. So if there's a concern, you can always do urodynamics, but if there's not, I think it's absolutely fine to go ahead and do any of the third tier options, because it'd be very appropriate.
Okay. All right, super. Let's I just asked that. Sorry. Okay, Sandy, I'm going to ask you for a few words about PTNS and how you do it. What are the pros and cons? I'm going to hand the slides over to you and have you give us a little talk about what PTNS is for starters.
Okay. We're going to go to my screen, and hopefully everyone can see this now. I'm going to go to my slide share view. Okay, so we're going to talk about PTNS. How do we do it, and what are the pros and cons? So what is it? It's a neuromodulation technique. So if you follow the nerve roots, as Dr. Kabash will speak about sacral neuromodulation, that works up on the sacral nerve roots. And if you follow some of them down all the way distally towards the feet, toes, ankles, that same nerve root branches out to one of the distal branches, which is the posterior tibial nerve. And that basically relies on something called carryover. So what carryover basically is that even though you may do a treatment, let's say today, Friday, you want that patient's bladder to still respond on, say, Sunday or Monday. And so how does that work? That in the peripheral nervous system, perhaps more so than the central nervous system, there's a strong belief that the peripheral nervous system does have, the tibial nerve could still have carryover phenomenon. So it still works, even though it's not being actively done on a regular basis. I think for our patients, we will tend to refer to them. It's very much like acupuncture. So it's not anything very invasive. Most of us who've even been trained years ago with the nurses and technicians who do this, will a lot of times have the reps actually showed our nurses how to do it, and they showed on themselves. So pretty simple and straightforward to do. It's a 34 gauge needle that we place in the area of the posterior tibial nerve. Those patients then get the stimulation for about 30 minutes done in the office setting. It's done once weekly for 12 weeks. And then to maintain the continued benefit, it has to be done on a monthly basis thereafter. I won't go into huge amounts of detail on the data, but just understand it's pretty good. It's been FDA approved. It's been done, a significant amount of the research trials have been done outside of the United States. And then several years ago, FDA approved and popularized in the United States. But it does require some travel. So as Dr. Ginsburg mentioned, you have to come in once a week. So think about the practical level for a patient, especially those who live far away, or for those of you who have office practices where you have to pay a fair amount to park, co-pays, things like that. I mean, these are things that become impediments for the patients to come in for a routine flow for their tibial nerve stimulation. So you really need to think about that when you counsel patients as to whether or not they need to do this. So again, as in this picture shown, a 34 gauge needle typically will measure about 4 finger breadths up and 1 to 2 back from the medial malleolus, and then place this 34 gauge needle. We'll turn the stimulation up. They'll typically get a little ipsilateral toe flexion, and almost like a little wiggle in their big toe that tells you that you're on the right spot. And then the grounding pad and electrode placed as well. And then using that for about 30 minutes. So the patients oftentimes are reading a magazine or something for about 30 minutes. And then the needle is removed, and then they come back a week later and continue to do the therapy for 12 weeks. And then once a month again thereafter. And technically that is, indefinite. So the needle's typically near. It shouldn't be really a painful thing. It's near, but not necessarily on the nerve. And then it's really low voltage stimulation. So patients shouldn't feel a significant amount of pain with this therapy. Sometimes patients themselves, if they're really, I had a nurse once who said, I think I know the spot. Can I just do it? And she would come in and she would do it to herself, obviously in our office. So pretty neat there if you have the understanding. Some significant contraindications you should be aware of: cardiac pacemakers and defibrillators, pregnancy and those seeking pregnancy, and those with perhaps significant enough nerve damage, so neuropathies. I would also put sort of a relative contraindication is really those with really edematous legs and kind of fat ankles, because to get an optimal stimulation, you're just going to have a problem because it's hard to find the spot when patients have a small needle going into a large leg or ankle. So the patients tolerate it well. I think they tolerate it exceptionally well. It really has hardly any success rates. Any problems or pain. Success rates themselves, probably a little bit better than medications, but not a whole lot. And so that's where, when we wrote the guidelines originally, and Dr. Kabashi mentioned, we don't really need to do these therapies hierarchically. And despite the fact that it is listed as a third line therapy, one can consider, approaching this first or second line. It is a discussion. And unfortunately, sometimes, insurance companies will have their way and really feel that there's not optimal, precedent before they go on to third line therapy, in this case with the tibial nerve stimulation. The durability factor is the one thing that there is belief you still need to persist with the therapy, even if it's less frequent, even if it's once a month. There's been a variety of different techniques done where you do it more often, maybe a little longer, things like that, again, I don't think anything's been fleshed out. So still the company manufacturer recommendations are once a week for 12 weeks and then once a month thereafter. If it's not working, I guess the big question is, when does it start to work? Most patients will oftentimes not see any significant results for about 6 weeks, and they start to see results, and then it takes a little longer. So, if you expect results in a week or two, you're going to be disappointed. So, if it's not working, one can still go on to additional therapies. As we'll talk about, onabotulinumtoxinA injections in the bladder, or sacral neuromodulation as various other treatment options. There is some data that does suggest better efficacy combined with medications. But again, now you're introducing overactive bladder medication side effects. You're adding cost, And so that's something you have to ask yourself if that's really much benefit in the overall scheme. And again, we usually have to encourage these patients to do this on a weekly basis so that they continue to see the best benefit at 12 weeks. And then obviously, as I mentioned, the maintenance therapy is going to be their routine. Some of the unknowns, and we'll touch base on some of this, that if you do this therapy more often, can you get a better benefit? In other words, there have been some protocols where maybe a slight additional benefit by doing it 2 to 3 times a week. Again, ask yourself the practicality of being able to do that. And how about something that achieves better patient compliance? Well, as I transition into the last part of the talk today, we will touch on some of the implantable tibial nerve therapies, because they sometimes obviate these issues of travel and more additional therapy, because they're being done on a more routine basis to maximize the benefit of that peripheral nervous system. So again, take home messages as far as tibial nerve stimulation goes. There's a lot of pros, not many cons. And when I say cons, I'd really just say that the travel, the need for repeated or continual therapy, as well as the question mark of really deep, how much benefit it does achieve above and beyond overactive bladder medications alone. It's clearly the most minimally invasive option, and some people would say it's even less invasive than medications themselves. As I mentioned, the practicality issue must be weighed in. If a patient can come for repeated visits, we're going to be getting into winter time in Cleveland, and that can be a factor. So thinking about that as opposed to other times, and again, locations and cost. So I will stop my screen share there, and then transition to the third case of dual incontinence.
While we're doing this, Sandip, I want to ask you a question. What if somebody is halfway through their therapy and they don't feel like it's actually doing that well for them? What do you tell these patients? Do you say, well, okay, let's quit? Or do you say, hang in there and let's finish the 12 treatments? Or what do you say to people when they're not seeing much difference?
Yeah, I think that's a great question. If it's a few weeks in, I'm going to ask them to at least get to 6 weeks to 8 weeks. Because we do see patients sometimes turn the corner at 6 and 8 weeks. After that, yeah, I'll be honest with you, I'm getting to be a little bit of a cheerleader to say, hey, should we have you finish the full 12 weeks? It is a bit disappointing when a patient makes it at 8 and 9 weeks and you happen to bump into them, because again, oftentimes, we're not the ones doing the therapy, your nurse is, but you happen to, be in clinic down the hall and hey, how's it going? And not so good. And it's a little disheartening. When they're 9 weeks, 10 weeks in, and you're like, okay, give it another couple of weeks. I possibly would pull the plug, so to speak, on someone at 8 or 9 weeks, because I don't think they're going to turn the corner at that time. To go the full
I
12.
have seen patients, and there is some data that shows that the full 12 weeks is important, but it's the cheerleader thing, right? You really have to get your patient through that and have faith. But they do need to understand that it's still possible that they may get out to the 12-week point and not have what the outcome we wanted. How about, I was going to ask you a question and it just slipped my mind.
Well, while you're thinking, KK, for both of you, how do you handle that follow-up? So, your PA, your NP, your nurse, whomever is doing the PTNS. Do you see them back at 12 weeks? Do you see them back at 6 weeks to have a check-in and say, hey, don't worry if you're not doing poorly or whatever? How do you usually get the patients through those initial 12 weeks?
Yeah, Dave, I think that's a great question. And again, you have to ask yourself in your office flow, we're already, seeing new patients, follow-ups, and then this, tibial nerve patient kind of floats back in, hey, not really seeing the benefits. So we will ask for some level of a subjective improvement scale. So we will tend to do, the UDI-6, so Urogenital Distress Inventory 6 short form, and IAQ-7. So trying to get a little bit of a baseline and then see how it's going at 6 weeks. And if, again, they're not really responding at all, we'll ask, do you want to continue this therapy? If you want to do, so much as voiding diaries, I think you're going to get some more objective improvements or not demonstrated there.
And when do you follow up with them, Sandip, during their treatment? I usually do visit 1, visit 6, visit 12, which is a little bit based upon the studies. Is that what you do too?
Exactly the same. Yeah. So, what at baseline and then at 6 weeks and then 12 weeks.
Yeah, just to see how they're doing and give them a little boost of encouragement. There's a question in the chat that asks about what you quote as your success rates for PTNS. So what do you guys usually quote patients?
Yeah, I guess I'm saying probably in the 40 to 50% range. Again, in a patient who has never been on medications, it's a little different. But if they totally failed medications, I'll be honest with you, I'm not doing much posterior tibial nerve stimulation unless they really push it with me that that's the therapy that they would like to choose. And it's simply based on really a lack of refractory data in this patient group. How would you guys handle that?
And I think setting expectations, is important as well in regards to, it's not only, how many percent of patients will improve, but talking about their degree of improvement.
Yeah.
Such that, especially those that have more severe degrees of OAB and urgency, frequency, urgent incontinence, that we're not going to make you perfect, but hopefully we can have enough of improvement that you're going to be happy with the result. And are you at the end of that 12 week, are you happy enough where you just want to keep coming back and seeing me every month to get this done, versus we have other options? And which would you like to do if this is your first of your third tier? So,
I think that's the tricky part about PTNS is the practicality of it. Again, coming back to that, if they're driving into the city or driving through the snow or whatever, it has to work well enough. Some of the data, the initial data was promising. And I think that's kind of led to some of the future treatments that are out there. I think PTNS in theory is really great. It's sort of the practical side of things and having to come in. So if you have batteries or things that can be implanted, maybe that changes the game a little bit. I quote a little bit higher just because of the initial data and some of the studies that we were involved in at about 70%. But the point is, to both of you guys' point, that it depends on what you define as success, right? So it's not necessarily 100% dry, it's improvement, enough improvement that they're satisfied. So, and I think that's a big piece of this. So let's move on then to a gal with dual incontinence, 46-year-old woman. We call it dual incontinence when they have both bowel and bladder issues, and that's a terminology that we're using more and more these days. She's failed first and second line therapies for overactive bladder. And she has fecal incontinence, which we now call accidental bowel leakage, in spite of high fiber intake and physical therapy. So, in her, I think this one's a little bit easier. OnabotulinumtoxinA is not going to help with the bowel. Sacral neuromodulation or PTNS would be the better thing. Sacral neuromodulation, as you know, is FDA approved for bowel as well. So generally speaking, this is the one time where I think that, or one of the times where I think that the answer is a little bit more clearly with one modality over another. So sacral neuromodulation, I'm just going to give you a couple little tips on lead placement and how we counsel our patients and that sort of thing. You can do a PNE, which is an office-based percutaneous nerve testing session in the office setting. The lead is now timed, so it's a little bit more secure and it doesn't migrate as the older ones used to do. So PNE is very reasonable if the flow in your clinic allows that, or staged, which is what I tend to do. But, at Virginia Mason, we do both staged and PNE, depending on which office setting, which a clinical setting we're talking about. I think it's very important to really set things up in your clinic to make sure it's not disrupting everything or tying up a room unnecessarily. So I think that's just going to be a very personal thing in everybody's practice, what works best. Again, I tend to do staged in the OR because I know that the lead that we place is the lead they're going to walk with eventually when hopefully they have success. I think this is a real opportunity, as is PTNS, to really engage your staff. And that is critical for the staff to really feel a big part of the successful treatment of our patients. They really feel empowered when they are part of the programming or part of the counseling and the teaching. I think it's really valuable just in that alone, that the staff really becomes an integral part of the team. And so they can program and educate and interrogate the devices for you. And it really helps with the flow, but it also helps with their engagement. So optimizing lead placement, are we doing the best that we can? Now, when we first started doing this, we used to cut down with an incision. I don't know, I mean, David and Sandy remember this, but a lot of people, it was way before your time, we would cut down to the bone. Now we use a percutaneous technique, which is so far refined compared to what we started with, and much more precise and very satisfying for the clinician also, because we can predictably achieve stimulation in all 4 electrodes under 2. We used to walk from the OR with 1 or 2 electrodes at 7 or 8 and be satisfied, but now we won't leave unless they're under 2, with rare exception. What you're aiming for is the superior medial aspect of the S3 foramen. And there are things that you can do to make this absolutely possible and reproducible. It is possible. When I first heard this, I thought, and now it's been, many years, when somebody said to me, yes, you can do this. It's very possible, and it's very reproducible in the vast majority of cases. Okay, so the reason why you want it to be in the superior medial aspect of the S3 foramen is because you want it to follow the course of the nerve. Okay, so there have been several advances over the years, not only with our placement technique, but with the lead and the curvature of the lead. Now we have a sort of a hockey stick guide wire stylet that goes into the lead. We've always had that in the kit, but now it comes loaded that way with our new MRI compatible options. And that follows the curvature of the nerve. If the nerve is going straight and the lead, if the lead is going straight and the nerve is curving, it's not going to follow it optimally for the whole length of the lead. And so that's the reason why we now have a curved path. So using the landmarks, I think this is really critical. We didn't used to know the landmarks, but using fluoroscopy, we can really reproducibly target the points that we are aiming for. So you use the C-arm and you can image the sacrum and the coccyx, both in the AP and the lateral. I'm going to show you some specific landmarks that we like to use. I like to use a drape that's transparent. It's a neuro drape. Actually, they use it for spine surgery, as I understand it, but it has ioban in the middle and the whole drape is clear. So you don't have your representative who's helping you at the foot of the bed crawling underneath this drape. They can just see things pretty easily through this, and you can see bellows and everything through this transparent drape. The clinical goal is bellows and great toe plantar flexion. So let's look at that. So to locate the medial edge of the foramen, again, I'm showing you beautiful x-rays, but you can see very clearly here, you can see the medial aspect of where your foramen is going to be. So we mark that out. We put a little dot on there, and then we go to a lateral. And the landmarks I like to use is where you see the SI joint, where you see the curve come in here, it's going to be the next foramen down. Okay. And again, these are beautiful films to really that exaggerate the point, but there's what we call a hillock, which is like a bump here. So the first bump down is going to represent your foramen. And you want to be about approximately a centimeter above the apex of that hillock. So if you aim for that, and what is the angle of your needle when you put it in? You want your needle to be parallel with the bone seam, which again is very beautifully illustrated here. The other way, if you can't see bone seams very well, you can actually put it in approximately perpendicular to the anterior aspect of the sacrum. Okay, so these are just to locate where you want to be. And then when you put your needles in, you want to really take relatively frequent spot checks, not big, long, live fluoro, but spot checks just to see what your angle of your needle is so that you can keep it in the right trajectory, the right vector, and in the right level. Okay. So again, approximately 60-degree angle from the skin, but that's not 100% of the time. So you want to play around with it a little bit. And the depth of it is also variable depending upon the patient's size. But then you want to stimulate and look for your plantar flexion and your bellows here. Okay, this is for those who might be taking any exams in the near future. These are very fair game questions. S2, you're going to get a rotation, so you can feel the buttock kind of twitch, or you can feel the calf rotate a little bit or twitch. That's one level too high. So if you're getting a rotational kind of a whole hip movement, you're one level too high, so you want to move it down. Again, our aim is for bellows. Bellows comes from these things that you use to fan your fireplace and great toe flexion. If you get bellows only, then you're one level too low in theory. So using this, you use both the fluoro and you use your motor feedback that you get from the patient to really kind of help with the precision of your placement. Okay. And what you're aiming for ideally is this sort of medial placement. You can see right along this bone, the edge of the bone with a outward flare like this. There's some talk about, if you can look at the distance between those electrodes, you can tell if it's moving laterally or moving away from you. But what I really want to see is just this outward hockey stick. And then here, this is actually not even as much curvature as I usually like to see. I like it to dip down, but you can see it's not quite a centimeter, but it's a little bit above that hillock, you see. So here's that SI joint coming in, and the hillock, the next hillock down is S3. And you just try to aim for, the bottom line is you want optimal clinical response more than the x-ray. So if I get not such a great looking x-ray, but I've got great clinical response, I'm going to take it, right? So I always say to our residents and fellows, the enemy of good is better. So you can't have perfect everything all the time, though a lot of times you are able to reproducibly obtain that. As a matter of fact, that gal, she had something happened and we had to revise her. So this is that same gal that I just showed you. And this is just a little bit better if you look at it compared to the other, and with the dip down, and somehow hers is just a little bit lower than it usually is. But again, you go in clinical response, and she had quite a bit of improvement just with revision of the lead. We are doing a little bit more revisions these days, now that the MRI compatible lead has come out. So people kind of coming out of the woodwork saying, I actually needed an MRI for my knee. So we'll go ahead and revise them, hook it up to the same battery, assuming the battery life remains good. This is that same gal. So this is a comparison side by side of the AP from this one to the revision, just a little more medial, and that makes a big difference. And her lateral, same thing, about the same level, but this nice curvature down. So that's the same patient with the revision. This is not right. These are real pictures. They're not our pictures, but they are pictures that we've seen. And, again, I always say to our residents and fellows also, do not judge what we do, what we did 5 years ago or 10 years ago by what we know now, because we just are better at it. All of us are collectively better at it. And it takes a little bit of practice, but we can't judge. And I'll tell you, I myself, I even put it in here, don't judge early replacement by what we know now. I'm going to show you the evolution with permission. This patient is a longtime patient of mine. She was one of my first patients. And you can see, first of all, these are the really old leads where the lead electrode number 1 was really long, but you can see this is absolutely unacceptable by today's standards. And now she's an idiopathic retention gal and has done very well. But these little ghost leads that we left in there because they were so deep, you can't get them unless you go anteriorly to get them. But this is just the evolution of things from 1999 or 2000 or so, when we were doing it without fluoro and without knowing the things that we know now. These could even be a little bit more medial, as you can see here, but level wise, they're pretty good. So I show this unabashedly just to demonstrate that even in our hands over the history of things, you can tell that we've just gotten hopefully better at things as time has gone on. So I think, again, the considerations when you talk about sacral neuromodulation are, there are some complexities to the therapy, programming, interrogating the device, all of that. I think once you start to practice, it becomes part of your flow. So I know that getting started, people feel sort of like it's the hassle factor is something you don't want to deal with to introduce this into your practice. The representatives from both of the groups that commercially have this available now are extremely helpful and really can get you launched or help you in your office and come do this programming and teaching with you. Now, if the interstim is not, if the sacral neuromodulation, or either of those are not working, you do have to consider, is it a programming issue? Do they have stress incontinence? Have they had stress incontinence all along, or have they developed stress incontinence? Do they have a urinary tract infection? These things. So think about not that automatically that this thing isn't working, but that there are other reasons why it may stop working all of a sudden or not be working as optimally as you'd like it to. And then combination therapy, as we've touched upon, is a very reasonable consideration. So you can add medication back in there. We also have some patients who have both sacral neuromodulation and onabotulinumtoxinA. That's rare, but it's not unreasonable to consider that because they're different mechanisms and strategies. So the take homes for my part here is that it is absolutely possible to get all 4 electrodes under 2. Just use the landmarks and practice. So don't get discouraged. Practice. The thing is that all of these things that we're talking about today can really make a huge difference for patients' quality of life. So it's really worth getting through that learning curve because it's so satisfying both to the patients and to us to be able to help patients that successfully. So do practice and don't give up on it. Give the patients the best that you can give them. So with that, I think we are.
Yes. A couple things. Yeah, I was thinking about when you say practice, and I just think about when we have fellows and residents go through the case. If you haven't done this a lot, you actually get a lot, you may get a lot of practice just on 1 or 2 patients because you continually are trying to pass that electrode. You may make multiple passes. Mm-hmm. And once you've done 2 or 3 patients, you've actually gotten a lot of practice in when doing that. And to your point, the folks that come and help out from the company are very helpful. A lot of them have a lot of experience. And they're going to help you walk through. And then a question for you, KK, you talked about both PNEs and permanent electrodes. Mm-hmm. And you said a lot of the decision is made just on where you see the patient in the office. Do you have a preference in what you would do if you could do both in the office?
So, a lot of it comes down to flow. So as I mentioned at Virginia.
So actually, now that do you think we need to talk about that just to explain the difference between the two?
Between PNE and yes, we can certainly do that.
We probably should do that. Go ahead.
No, go ahead. I'm talking too much. So go ahead.
PNE is an electrode that is thought to be temporary, and we're doing that in the office, and it's going to stay in for a week, and it's not your permanent electrode versus one where you do it in the operating room, and that's the electrode that is going to, if it works, will be the permanent electrode to use long term.
Right. So, the thing about PNE is that if it doesn't work, you're going to do staged anyway. So, therein lies my sort of internal conversation about whether or not I'm going to do PNE. But a lot of it really comes down to the flow. So at Virginia Mason, we generally, when we do PNEs, it's generally going to be in our sort of satellite offices. And then in the main, we don't. That's not 100% true, but it comes down to the flow, right? So if it's really going to tie things up, then just do it in the OR and do it staged. But again, it's one of those things that really engages the team. And that's a valuable piece of things too. I think.
So you said if you're going to do a PNE and it works, you're going to go and do a permanent lead, right?
If the PNE works, then you just put the whole thing in the OR in one stage.
Right.
But if the PNE is not successful, then you do a staged anyway. So then they get 3 procedures. So
right. I'll make sure that it's for folks that don't do this. Everyone that has a poor response to a PNE doesn't mean they're not responders, because we don't think we always get the optimal response to the PNE. So it's still someone you can do a permanent lead trial on. Mm-hmm. So the argument there would be, are we wasting our time with the PNE, or is it a good screening tool? And you can make the argument for both, I think.
Yeah, you absolutely. I don't think that one is better than the other. It's just your style and your flow. What do you think, Dr. Vasavada? We missed.
I was just going to add, and a great discussion here. You have to individualize with the patient, and it's hard to get a sense of how squirmy they are. But if they are very squirmy, I think doing a PNE can be very challenging for everyone involved. So that patient, if you can get a good read on them, and I remember a lady who, she's on the table, she's ready for the PNE, everything. And she's like, well, you're not going to use any needles, right? Because I have a fear of needles. I'm like, oh my God. So yeah, you have to think about that, and that patient may be more ideally suited for a staged approach. That said, when you have the opportunity to do a fluoroscopic placed PNE wire, and as Dr. Kabaji mentioned, the newer technology in the last year and a half or so has really perhaps advanced things in our opportunities to do a good stable PNE that's going to stay into position as opposed to the prior PNE technology. So we've been seeing actually almost similar results. Now, I would only couch our data and experience by saying that these are well-selected patients, body habitus as well. If someone's too big, and we get definitely a different size patient in the Midwest than you guys get on the West Coast. To that end, I won't even bother trying in the office. I'll just say, well, we're going to do this in the operating room, and you're going to get a good response, and we'll go from there. So I think you have to think about those types of elements too.
So Sandra, that's actually a good point. So with the newer PNEs that theoretically are more stable and not going to move, if someone has a poor response to the PNE, will you still give them a permanent lead trial, or do you think it's probably not worth doing that for them?
Yeah, no, it's a good question. Again, if I think I had a good, lead position, and you can remember, almost by default, the PNE is bilateral, so you get at least 2 tests instead of 1. And I know there was a question I addressed in the chat box about dual leads, which is not FDA approved for the stage 1 leads, but the standard has been bilateral for the PNE leads. Mm-hmm. I will, David, I think that's a great question. I will. And I will oftentimes, again, when we're talking about language and stuff, I'll say, well, you had a suboptimal response, or we didn't quite get the answer we were looking for. And so I'll tell them very much up front, because it's somewhat disappointing when we have a patient like, I just forget this. I don't want to go on to the next step. And maybe it's just you didn't get a great, maybe they're moving too much, or you just couldn't see things well, or any number of factors that precluded a good test. So
there's a question about length of trial. And would you use a 2-week trial for someone with incomplete empty urinary retention? Yeah. So I actually do 2-week trials for everybody. I do think it is better with an incomplete to have a longer trial, but I'll do 2-week trials for all of the indications. Do you guys do anything differently with a permanent lead?
I do the same. I mean, sometimes we'll do a 1 week if there's just scheduling issues, but generally speaking, I do 2 weeks. And then for idiopathic non-obstructed urinary retention, we might even go to 3 weeks off label. That is off label. I probably shouldn't even say that, but because it takes longer. I mean, it's a little bit more stubborn. And there's some great questions in the chat. I just want to make sure that we have addressed that one. Do you guys have any other? I want to do these kind of real time. And I missed one on Parkinson's and PTNS, so we'll loop back and make sure we get everybody's questions. Preferences between PNE and stage 1. I think we just talked about that as sort of practicality and patient style and flow of your clinic. Do you have patients alternate between 2 programs, 1 every 2 weeks versus get a good response and leave it alone unless the symptoms worsen? We will cycle through the programs. If they get one that's like a home run, we just stay there. We don't try all 7 to try all 7 if you get a home run, but we will say that you want to be at least a week on each program before you give up on it and move, unless it's a catastrophe. Like some are just like, don't do anything for the patient and they're miserable. You don't want them to be miserable for a week trial if you know that program isn't going to be quite optimal or it's not going to be good. But generally speaking, we'll have them keep a diary and until they hit the home run, which oftentimes they do as they're cycling through the programs. Anybody do anything different?
So I have a question, because I've gone round and round on this one. So say you have a patient that is doing very well, stable with sacral neuromodulation. How do you have him or her follow up with you? Because there was a period of time where I'd say, call me if there's issues, but then I think people fall through the cracks. So I now try to make it a little more of a regular 3 to 6 month follow up. Because then they'll come in and like, well, this hasn't worked they come out 8 years later, this hasn't worked for 3 years. Like, well, I know. Probably because your battery's out. I need to see you sooner. Sorry.
Yeah. We see them annually for that very reason, because they'll get used to it or they'll give up on it. And, it's a pain in the neck to come into the doctor's office, right? But if you just set that expectation that we want to touch base with you once a year, then when their battery dies, then it pretty quickly.
Yeah, it's amazing when you hear like how many people who just stop using it. Why? Well, I don't know, just stop working. Well, maybe it's off or their battery died, or again, they can be fixed with a simple reprogramming. So to KK's point, I would do an annual follow-up as well, and we can help a lot of them that way.
Yeah. And I think now as technology advances, and again, as our technique has gotten better, we're just getting better with time. So, if somebody had their implant placed in 2010, we didn't know the things that we know now. So I think those people too, maybe not getting out of it what we can offer. So we have been kind of contacting people, and the MRI compatibility is also something that's really been a game changer. Somebody here asked about, do we use fluoro guidance for PNE? Yeah, we do. You can do it without fluoro. There are some landmarks that you can use, but that will give you more optimal placement. How about you guys? Do you use PNE, fluoro for PNE?
Yeah, I think if your office lends itself to having that, or your flow, I think it's definitely helpful. But remember, even if you don't have that in your office, and let's say you had to, there's some services that'll bring in a C-arm fluoro, then you need to have a flow to have several of those cases lined up. Otherwise, it's probably just not worth your expense to have the fluoroscopy there. But yeah, we can almost always get a better one done without with fluoro, but without just doing landmark. But there's nothing wrong with doing if you're very comfortable and you're pretty seasoned doing these, you may feel that you're pretty good at a landmark PNE.
How are you?
Although I would say that we have resident or fellows mark things out, and there's that every occasional patient where what you marked out is nowhere near. So
That's the practice,
the fluoro is very helpful, and for those of you that don't use it a lot, if you're using a C-arm, it doesn't have to be in a fluoro specific X-ray room. So you can bring a C-arm in any room, and that works okay in your office.
Absolutely. How are you guys getting the PNE? Now, the PNE lead has some tines in it now, so it's a little bit more secure, but there's a question in the box about how you guys get your PNE lead to stay put for 2 weeks. What's your technique of securing it with your steri strips, or however it is that you secure it?
Well, again, remember the new PNE wire, it's almost like a slinky, but to pull that out or displace that from its original position is rather difficult. So, I don't find that I have to do anything special to actually anchor it into place. We'll just tape it down with a tegaderm. And then, the other thing that we've kind of followed is that, do you have to, once they get response, especially for those responding early, do you notice that you have to keep changing stimulation or amplitude? And the short answer is no, which perhaps indicates that it's not moving a whole lot in these patients, again, as opposed to the last PNE technologies that we saw before.
Absolutely. And I think that again, we're hammering this home, but as technology improves across all of these, we shouldn't give up on these technologies because they continue to improve. So infection rate slightly higher with stage 1 than with PNE? I guess in theory, because it's a little bit more invasive, we haven't had a high infection rate. We give them a dose of Ancef on the way to the OR, and then we give them Bactrim because it covers MRSA just for a couple of days. What do you guys do for antibiotics for your InterStim, or for your sacral neuromodulation? Forgive me.
Yes, we're not doing any for PNE. And then same thing for stage 1, like you just mentioned, with the first generation cephalosporin. And then, if not allergic, typically home with 3 days of Bactrim post-op.
Okay. Non-obstructed urinary retention. How do you address non-obstructed urinary retention resulting from Claudio equina, say 9 months after initial injury? Now, I usually wait a year. That's just dogma. But I think 9 months is probably okay. And I think it's worth a try. I mean, if you've proven that it's actually non-obstructed urinary retention, if it's Claudio equina, or you're going to get the result that you want, sometimes you might you might predict that it's not going to work, but I think because we have this ability to do a trial, I call it the test drive. Again, it's the language that I use. I should probably go through the language that I use, but I say you get to take it for a test drive for 2 weeks, and they start laughing. But then I said, then you don't end up with something in your body that's not giving you some benefit. You get to take it for a test drive. So I think with that ability to do that, I think we should give everybody the option to try it on, basically.
I would say theoretically, if you're going by, it theoretically would be off-label if we're doing it that, because theoretically that would be neurogenic urinary retention. And depending upon who is evaluating your authorization request, if they're sophisticated enough, they may not allow us to proceed. I've had that issue at times, but I agree with KK in that certainly there are times where a patient wants to give it a try. The downside is you may lose 2 weeks of a test stim. That would be it. I wouldn't say that I've had a lot of great success in that patient population.
Agreed.
So,
Great.
Yeah. And so back to the language, just really quickly, some of the words that I use to make it more friendly, you can scare people away by saying I'm going to put a a computer or battery in your, whatever in your pack. But, you can also say, listen, it's an Oreo sized cookie battery or silver dollar. It's tiny. If you do the rechargeable, it's even smaller. It's like a $50. We tell them about the battery life. And then I say, we do this in the operating room, not because it's a big operation, but because we want it to be as sterile as possible because we're implanting something. You don't get a big general anesthetic. You get colonoscopy sedation or wisdom tooth sedation and a little local anesthetic. And then you get to take it for a test drive. So I think all of those, and we call it a pacemaker for the bladder and that sort of thing. And I think just that more sort of friendly language makes it less intimidating than some of the words that we could use if we're, being more technical about it. You guys, any other thoughts that you have?
Yeah, same.
Okay. Let's see. There's a question in there that we skipped before, and we're going to be talking about neurogenic bladder next. So the question about PTNS and Parkinson's, we'll talk about neurogenic bladder, and I'm sure get into this sort of a discussion. Lastly, here is there anything on your dynamic study that may guide you to Botox versus SNS? Well, we're going to be talking about Botox in a second also. So why don't we save that, because I think our conversations are sort of developing into these more discussion-like things. And so we'll try to address that. And if we don't specifically, we'll circle back to it. So at the end of the day for SNS, I think, it's really engaging your staff. Consider batching, like if you're going to do it in your office, like do a whole day of PNEs or a whole morning of PNEs instead of one in the middle of the flow, because it just really can, put a lot of speed bumps in your flow. Lean on your industry representatives. They're excellent and they can really make life easier. So don't let that be a reason why you wouldn't try it or integrate this into your practices. And again, I want to stress, we all get better with time. That's why I showed you my horrendous placement from early on, because we've all done that. I think now with the tools that we have, you shouldn't do that anymore. That wouldn't be acceptable, but we can all help each other get to the place where we're more consistent about our placement.
Okay, I might just mention something real quick on the leaning on the industry representatives again. Just to understand, they have a different vantage point on the table. Typically, they're more at the feet. And so they can see kind of as your needle angle, lateral to medial, are you off? And maybe, again, unfortunately, as surgeons, sometimes we have these egos that drive us. And this is perhaps one area that, put your ego to the side, listen to your rep. As I mentioned, they have a different vantage point. They're doing these all day, every day, and you're doing them, in the midst of all your other, procedures you do. So they have a wealth of knowledge and experience. So listen to them.
Absolutely.
To Sandup's point, I'm also moving a lot when I put a first stage in, because I'm looking from different vantage points in terms of where that needle's going. And oftentimes I like to lean kind of over, say, the thigh. So you're looking at that angle in a different way than if you're looking laterally just across the patient.
Absolutely.
Because it really helps you try to get that needle into the right spot. But absolutely, I agree with Sandup that the folks in industry are very helpful, and they're helpful in many different regards, not only putting the electrode in, but we all in our offices have our staff that help with programming. I am not the programming expert at USC Urology at all. We have a PA that does that. But if there's someone who's not getting the response that we think that he or she should, we'll try to batch a couple of patients in, and we'll have the rep come in and do maybe theoretically a higher level of programming. So it's another way you can take advantage of your reps to try to get an optimal outcome. Yeah,
we actually have a couple of days a month that are set for the representative to come into the office and just like see 4 patients and help us interrogate their devices and that sort of thing. And then to Sandy's point, I label the representative our eyes at the foot, the eyes at the feet, because they'll say hub away from you, hub towards you, stand up. I mean, standing it up and that sort of thing is something that we have to learn how to do. But the medial to lateral aspect, if you want it to be parallel to the longitudinal axis of the patient. So if you're just a little bit medial and you can't see it because you're standing on the side of the bed, the eyes at the feet can really help. So everybody laughs that we call that, but that's their nickname. So in the interest of time, I see some questions in the chat. We will circle back to it, but just to move things along and get this last case in there and a little bit of eyes on the future, let's just go on to this 46-year-old gal with multiple sclerosis and OAB, of course. She's failed first and second line therapies, and she has diffuse overactivity on neurodynamic studies. So David, what's your minimal evaluation in a neurogenic patient? Is urodynamics necessary, and what are you looking for?
So now that we actually have a neurogenic lower urinary tract dysfunction guideline that is going to be presented at the annual meeting on Sunday, I could actually spend a lot of time on this answer, definitely, because we have a whole risk stratification system. But for this patient specifically, and I'd say, please come listen if you want to hear about it on Sunday at 3:30, I think it is. I think for patients with neurogenic lower urinary tract dysfunction that have an unknown risk stratification, we need to understand where they are, and we'll do urodynamics. That being said, if I have especially a young MS patient, especially a woman who I'm not worried about bladder outlet obstruction, they clearly have overactive bladder type symptoms with urgency, frequency, urgent incontinence, and they have a low PVR, I won't necessarily get urodynamics. If I think I need to get it, I'm worried about emptying issues, I will get urodynamics. And if I think it's someone that's going to move into botulinumtoxin therapy because they failed oral therapy, I will often have them set up for urodynamics, possible botulinumtoxin injection, the same visit, just to make things a little more efficient.
Perfect. Okay. I think I'm to hand this over to you. Oh, Sandy, are there any third line options that are not good options for an MS patient or this particular patient, and why or why not?
Yeah, again, I think, depending on level of neurogenic involvement, again, as we mentioned, FDA approval technically doesn't really allow for these neuromodulation patients to be done for most neurogenics. And then, as Dr. Ginsburg talked about, with self-cath and the potential need with onabotulinumtoxin injections, it's going to, start to, push you in one way or the other. So I think you have to weigh all these other factors in. And, there's mobility issues that are going to, have a factor for some patients and a handful of other things. So, yeah, I think you just got to factor these other things into play when you make your decision or recommendation with the patient.
Yeah. And I think, now that there's MRI compatibility, this changed the game a little bit, right? I mean, it used to be that this question would have been a different answer, 18 months ago. But so I'm going to stop sharing here. I'm going to hand it over to Dr. Ginsburg so he can talk a little bit about, obviously Botox. We've kind of set this up so that everybody has a chance to talk about different modalities for you.
Okay, good.
Good.
You guys see it? Perfect. Okay. So we're going to switch a little bit, talk about botulinumtoxin. We're going to talk about how we inject in terms of needles, scopes, and templates, per-procedure antibiotics, and then selection. When we talk about selection, not only dose, but patient selection and who is a really good person to inject and maybe someone we may want to avoid. So when you think about the prep, and we've kind of talked somewhat today about just trying to make things easy in your office. So what's the prep of the patient that's going to undergo an injection of botulinumtoxin? Well, in my office, they get 50 cc's of 1% lidocaine in the bladder. Why is it 50 cc's? Because that's what our vial is in our office. I have another office where it's 30 cc's. It's just something with lidocaine in the bladder, lidocaine jelly to the urethra, a betadine prep to the urethra. The botulinumtoxin is diluted. I put 10 cc's in one vial of onabotulinumtoxin. Remember, don't shake the vial when that occurs. And the antibiotic, the needle's out ready to use, and the antibiotics in the room to be given after the injection. And I want to stress that all this is done by our nursing staff. So all this can be done before you enter the room. So while the patient's getting prepped, you could be seeing patients in another room, really try to optimize your time. So the actual injection is going to take you 5 minutes, and you don't have to deal with any of the prep activity. So think about questions that I hope we can address and answer today in terms of dosing. So it's approved for 120 units, depending upon whether it's overactive bladder or emergent diffuse overactivity. Scopes, using flexible or rigid scopes. Needle options, which again depend on the scope we're going to use. And what's important is if you're using a flexible scope, you're going to essentially need a third hand to do that. It's hard to do with just two hands using a flexible scope. Templates, there are a variety of templates that are out there. And then what is the appropriate post-injection evaluation? So here's an example. This is a patient that I injected years ago. I had the video set up. She's a Parkinson's patient. She was about 2 hours, because I was late that day, she's about 2 hours overdue for her Parkinson medication. So I'm not doing this on a boat in the middle of a hurricane. She's actually was shaking because she was due for her medications. You can see what I'm trying to do in terms of getting kind of that subtle rise you see there when you do the injection. I'm using a flexible scope. I do 0.5 to cc per injection, depending upon the patient. That's 5 to 10 units per site, 10 to 20 sites. Trigone is something that I'm not looking to inject, and I think the trigone can be harder to inject if you are using a flexible scope. But if I can get it, I will get it. I think it is more likely to bleed. And again, you can see the depth you're trying to get. Although I think if you get one of those blebs, I don't think it matters at the end of the day at all. So, and then the question is often, which scope should I use? Right? We have a variety of scopes that are available. So theoretically, for female patients, use a rigid scope because it is easier. There's a cheaper needle for their flexible rigid scope. It's easier to stay on template. I do think with the rigid scope, it's harder to get out to the lateral wall because the legs are going to be in your way when you're trying to get out there at times. But you also can do this independently. You don't need your nurse because 2 hands are sufficient. That being said, I'm never injecting someone without a nurse there to begin with, it's chaperone. So it really doesn't matter. I'm going to have someone there to do the injection with me. Now, that being said, in our office, we just have flexible scopes. It's all we have. For whatever reason, that's how we've evolved at USC. So I use flexible scopes for everybody. Certainly, it's easier for men. The flexible scopes are more expensive, and they're more expensive for 2 different reasons. The needles themselves are more expensive. And there's always just the risk that if we take the needle out inappropriately, you're going to damage the working channel, and that unto itself certainly is not cheap. I think the template, at least with my experience, is fine. But I think if you're a new injector with a flexible scope, it's very easy to get a little confused as to where you are. And just like with neuromodulation, with a little bit of practice, you're going to be fine. And at the end of the day, I'm not sure that it matters as long as the botulinum toxin is getting in the bladder. That patient's probably going to do pretty okay, although there's no data to suggest that. And again, you need that third hand to make that happen. In terms of needle, I'm going to break it down into needles you use for the flexible scope, needle used for the rigid scope. So this is the Olympus needle. I'd say this is the needle that I prefer to use, this needle that I like. So it has this protective sheath with the needle itself. So you can see that the needle's not out. You can see here, and then when you push it in, the needle is out. So you can pass this through the working channel protected, and then once you're in, and you push the needle out, it is, I think, the most expensive needle. Please don't share that with anyone at USC. But I think it has the most ability to allow the scope to deflect, and the bevel of needle is very sharp, so it's easy to get in. And when you need to make sure you filled your bladder up adequately so you can make sure you pop through with the needle. Cook needle, not overly expensive. You do have to preload that needle onto your scope because it has a little protective cover that goes over it. So you have to preload that needle on your scope, have it just inside the working channel and take off the protective sheath, and then pass the scope itself to make that needle work. And then there's the Labrie needle, which is, again, less expensive than the Olympus needle. What I found with the Labrie needle, and I haven't used it for several years, maybe that's changed, is that I can't deflect the scope as easily. It's a little bit more rigid. I think the needle itself is not as sharp as the Olympus needle, but what I do really like about this is if you want to change the length of the needle, you can do that with the way the Labrie needle works. And then this is the Williams needle. This is a needle that we use with rigid scopes. And you say, well, I don't really use rigid scopes because I don't have them in my office. But there is that occasional patient that says, Doc, I just can't do this in the office. It's too expensive. It's too painful. I have to do it in the operating room. So, it'll be hundreds of patients I have on rotation. There's a couple every year that we have to go to the operating room. So we use the Williams needle. One thing that I would say is you got to be careful of is right at this junction here. If you're not careful, you can get a bend on that, and either the botulinum toxin doesn't go in, or you think you're injecting and there can be a little crack in here and you're actually losing it off on the side. So that's the Williams needle, which works well as so. And then I guess the next question is templates, right? So what are our template options? So if you look at the package insert for botulinum toxin, this is what you're going to see. And this is what we all did on the studies that resulted in FDA approval. Now, I was one of the folks that new injectors called when they were going to enter the trial, because when the trial started, there weren't a lot of folks that were doing botulinum toxin injection. And based on some of the questions that I had, I'm pretty certain that everyone didn't really follow the template perfectly well. So does it mean we have to be on this template perfectly well? I don't know. But this would be the template you'll see on the package insert, okay? So what I usually do is a 1 inch, or if I'm doing for a patient with overactive bladder, 100 units, I'm usually doing 10 injections, focusing up really just off the trigone, more at the bladder base, may get some trigone if I can easily, but if not, I'm not going to worry about it. I do 10 injections. There's a variety of other injection options. There's alternatives that are looking at just really loading up 1 to 3 to 4 injection sites, whether you're using 100 to 300 units. 300 units is not the FDA approved. This was from previous evaluations for neurotransmitters overactivity. A newer injection paradigm is one that is, again, 10 injection sites like I do, but really going peritrigonal as well as intratrigonal. And this was presented at SUFU last 2020. And you can see the difference where we're trying to get the entire bladder on the standard injection template. This is really focusing again on peritrigonal and 2 on the intratrigonal area, really trying to focus really more where there's more afferent signals occurring, theoretically. I don't do this all the time. And again, I think that it can be challenging to get these 2 injection sites at times with a flexible scope. I can't always do it. I feel like I'm almost skiving it. And I also think that that's a chance for a little more bleeding, but certainly that is an option. And the whole idea is that if you're doing this, you're going to get more of the afferent target. And if you're getting the inappropriate, the thought is there's like, why are we having overactive bladder? And that can be a whole 2 hours of discussion itself. But is it too much afferent signal leading to urgency and frequency? And that's that urgency, then you're targeting those afferents and you're working here alone, you're going to have less urinary retention, less need for catheterization. So that's the thought behind that new template if you want to give that a try. Now, what about antibiotics? Okay, so again, if you look at the package insert, it says antibiotics should be administered for 1, 2, 3 days and pre and post treatment on the treatment day, and not using aminoglycoside. What do? I'm giving a patient 1 dose. You have used mostly quinolones, though not completely, and trying to move away from quinolones now, but 1 dose a day of procedure. I'm not worried about sterilizing the urine. I don't check the urine. But if a patient does have an active signs of the symptoms of urinary tract infection, I'm absolutely not going to inject them. But there's a lot of other interesting information out there in literature regarding urinary tract botulinum toxin and antibiotic therapy. So what do we know? So this is one that I think is important and makes the argument, makes me feel better that I don't need to check the urinalysis because the adverse rate, including UTI infection rate, was not impacted by the urine dipstick about analysis. One study comparing a single prophylactic dose to 3 days of antibiotics showed there was actually more UTI with longer antibiotic use. Another study showed 3 days of quinolone superior to a single dose of ceftriaxone. And there's this study and several others that I think are really interesting. And again, can lead to a much more of a significant discussion is that you actually see a lower urinary tract infection rate when you treat neurogenic bladder patients with spinal cord injury after botulinum toxin therapy. And that I think is really making the argument in terms of making that bladder a quote unquote healthier bladder and lower pressures and more able to deal with potential infections in the bladder that was pre-botulinum toxin injection. I think one of the more interesting things then is, do we use, and I want you to understand there's different doses for overactive bladder and neurogenic intrusive overactivity. And I also want to make that distinction. So the for overactive bladder, this is FDA approved for patients refractory to meds with overactive bladder symptoms. It's based on symptoms. And for neurogenic, it's for neurogenic intrusive overactivity. So theoretically, this is a urodynamic indication. And when you look at the catheterization rate for patients that have neurogenic intrusive overactivity getting 200 units, it was 30% on the botulinumtoxinA arm, just under 7% on the placebo arm. So I tell patients it's around 25% if we're going to use 200 units. I think one of the issues we had with these studies is there was no definition of retention and no strict definition of when we should start intermittent catheterization on these patients. And clearly, based on this data, we probably should have had some of these patients that were more the MS patients not doing catheterization at baseline, probably catheterizing before we even started with the botulinum therapy. Because of that, I think that if you're doing this for neurogenic patients, and while this botulinum toxin is FDA approved at 200 units for neurogenic intrusive overactivity, for those patients that are not catheterizing at baseline, I will usually use 100 units. And when you look at data that has looked at this, you compare the CIC rates, we've now decreased it in half with the 100 unit dose. So if you have a patient with neurogenic bladder, neurogenic intrusive overactivity, for me, 100 units is going to be used for those that volitionally void, low PVRs, want to avoid CIC or just unable to CIC. 200 units if already on CIC, able to CIC if they want maximum efficacy, or you failed 100 units. And in fact, I will even use 200 units, this is off-label, on overactive bladder patients that have failed 100 units, don't have a high residual. Maybe they had some improvement, but wanted to get a little more bang for their buck. Now, what are you going to do post-evaluation? So, and this is really more for the initial patient and their initial injection. If I have a patient who I'm injecting every 6 to 9 months, we know they do well, they've had multiple injections, we know they don't have a high residual, I don't need to see them back in 2 weeks. This is someone who has not been injected before, going to see him back in 2 weeks. And the nurses know when that patient comes in, they're going to get a urinalysis, that if we're worried about a UTI, we'll send out, if not, we throw it in the trash, and they're going to check a PVR. So when I go in the office to see that patient in the room, we already know what their PVR is. But the reality is, for me, it's all about symptoms. And I'm not going to start CIC based on an arbitrary post-void residual volume. And I have 350 cc's there, because if you look at the package insert, it says, consider starting CIC if the PVR is between 200 to 350. And if it's above 350, then you should start CIC. The reality is, patient comes in with the PVR of that, and they say, you know what, I'm doing great, I'm really happy. I'm not starting CIC on them, which then even begs the question, do I need to see these patients back? And its whole idea of telemedicine and the pandemic, it's actually changed what I do for my botulinum toxin patients after their first injection. I make them an appointment in 2 weeks, and they're set to come back and see me. But I tell them, if you're doing great, if you don't have any issues, we can make this a telemedicine appointment. I can check a PVR, but am I going to start them on CIC? I'm not if they're doing well. I don't really care how big the PVR is. So, well, theoretically, we should be getting PVRs. I'm not sure that you need to do it on patients that are doing well, because we're not going to start them on CIC. I do think it's important to appreciate that diabetics have a bigger risk of elevated residual and need for starting CIC. And just think it's part of the discussion when you're talking to these patients in terms of making decisions. You know, what are your potential outcomes and what are the risks and potential complications? And you might see that more with the diabetic patient. And then, can we predict who's going to do poorly? And that went to, I think there was a question about urodynamic data, and it's really somewhat of a mixed bag. We know that we see improvements in men and women in terms of quality of life. And on one study suggested that bladder outlet obstruction index did not predict the need for CIC. There's other studies that would say that men tend to do a little bit worse in terms of their response rate and a greater risk of CIC in men. Patients with a lower Qmax or a lower Qmax on uroflow would suggest that bladder contraction maybe isn't as strong. And if we take even less away with botulinumtoxin, greater risk for leaving urine behind in a prior hysterectomy. And then other data that suggests with a higher bladder obstruction index, you do have more issues. So kind of a mixed bag. But again, I think maybe be a little more careful in that male patient who may be at greater risk for CIC. Though there is some data that we're going to present at the ICS that shows that, yeah, it's maybe a little bit higher, but not particularly high. Now, we don't see a greater risk for retention over time. Patients continue to do well. So who's the right and the wrong patient? I think the optimal patient is the patient with certainly overactive bladder, urgent continence, urodynamic detrusor overactivity. Although not having detrusor overactivity on urodynamics is not a bad patient. We know that up to 50% of patients with urgent continence won't actually have detrusor activity at the time that we're doing the urodynamics. Able and willing to do CIC in the neurogenic patient population. And the suboptimal, I think that second bullet point, patients that have fecal incontinence are really, to me, we try to steer them to sacral neuromodulation. They have a high PVR at baseline. If they're not wanting to do CIC, it's not a good option. They have bladder outlet obstruction, not a good option. And that top one, I just want to make one little caveat. We certainly always say don't do this if they can't or won't consider CIC. But there are certain patients that I may do that. When you have maybe the MS or the Parkinson patient in particular that can't do CIC, but they don't really have any other options, and your next option may actually be an indwelling catheter anyway, then from my perspective, it's certainly worth giving a trial if they're mostly storage symptoms to see if we can make them better. So, I think this is my last slide talking about botulinumtoxin. That I think what I always tell patients is all of these options are not mutually exclusive. If you try one, it fails, you can try the other. So looking if patient has done neuromodulation first, there certainly is success with botulinumtoxin afterwards, and that certainly is a viable option. I think that was the last of my slides, and we were going to switch back to KK. Is that right, KK?
I think what we'll do is just go ahead and send it over to Sandip, and I'll ask him to give me the take-home slides, and we'll just summarize real quick this section and then talk a little bit about the future. But Sandy, there are some questions here about what your follow-up is for Botox. So after you do a Botox injection in the office, what's your follow-up? When do you have them come back?
Yeah, I think just like David mentioned, at about 2 weeks, if they're a new Botox patient, just to check a PVR, and very nicely how he stated, we'll check the urine, but unless they're having symptoms, we're not doing anything with it. And I think that was some of our data that we had from a little while ago, Samir Davrasar, one of our former fellows. So just even when the patient comes in, unless they're having symptoms, we are not going to really get into weeds about, canceling a Botox. And I think if you had asked me a few years ago, we were routinely doing that. But back to your question about follow-up, yeah, that's the usual. And then assuming they're doing well, we'll see them back at 6 months or whenever they need their second Botox.
So we're doing the same thing the 2 weeks. There are some patients who have had repeat injections and they never go into retention, and they say, I don't want to come in unless I feel like I can't void. And so, those patients we're okay with. We do tend to make an appointment for them as they leave now for their 6-month Botox. And then we say to them, if your symptoms come back sooner, give us a call. If you are approaching that 6-month point and you're not having return of your symptoms yet, then we can push it out. But that way it's a little bit of a placeholder and we don't lose them. I mean, I kind of think of it like when I, get my teeth cleaned or something, I sort of try to make the appointment on the way out so that you don't forget about it. Otherwise it becomes, years. The other thing about antibiotics is, when we used to do this off label before it was officially here, we were doing it without antibiotics. So our fellow is currently doing a, prospective randomized look at antibiotics versus no antibiotics. We are checking the urines, but we're really going on symptoms. So I think it's interesting. I think in this era of, antibiotic resistance, we do have to be good stewards of our antibiotics. And so I think these are really important questions to ask. I mean, a lot of this is dogma. But anyway, please go ahead. The future is here. This is a really interesting section that Sandip will tell us a little bit about what's on the horizon.
Right. So as David mentioned, we're still trying to iron out some things on the onabotulinumtoxinA and the injection templates. There's certainly some stuff that's going to be coming out with different toxins and how is that used. And was that necessarily going to work better than the onabotulinumtoxinA that we currently have and most of us use? Sacral neuromodulation, there hasn't been a whole lot more in the space aside from what Dr. Bashi mentioned with the MRI, compatible systems as well as rechargeable systems, which are newer in the last year and more. So a lot of the discussions have really come up with patients now on, tibial nerve stimulation or peripheral implantable tibial nerves. So that's what we'll talk about here. So looking at this from a case, a 64-year-old woman has failed 2 medications for OAB, so sort of standard index patient. She's not interested in the current 3 refractory overactive bladder options and read on Google that there may be some new options. How would you guide her on potential new therapies? So, these are things that are perhaps either going through the FDA approval process or pretty far into it. So it's very possible in the next several months that we may see some of these start to come to market. One of which option is the StimGuard. It's an implantable tibial nerve stimulation device. Ken Peters is kind enough to share with me his slides on this. It's a wireless micro implant. These are all done in the office. So what's kind of neat is that tibial space is very, I'll just say minimally sensate. So it's different than perhaps other parts of our body where, ouch, it hurts. This is something as an area, most patients, when you numb it up well, they tolerate things beautifully. So you can do these procedures very nicely, very well in the office, and you'll start to see some data about that. Again, you can see how small some of these devices are, and then it'll have to be wirelessly transmitted to achieve its stimulation responses. Perhaps the one that, at least to my knowledge, is perhaps farthest in the FDA approval process, again, not approved, but at least on the brink of it. The eCoin or electroceutical coin is a fully implantable tibial nerve stimulator. It's actually a primary battery and very similar to the coin that's shown on the side. A nickel would go in that same area nearby the fascia. And what you'll do, it's going to be right above the fascia. You place that, and periodically this thing will give intermittent stimulation, and it can stay in for many months. And it's a leadless design, and so that device itself gives the stimulation, and it's actually the battery as well. So it's pretty neat. Some of the data, and again, I won't go into much detail on that, is really pretty good. And so you're going to see that as it's going right now through the FDA approval process. A little bit before that, the Blue Wind therapy is now in trials in the United States. It's been done as well earlier to us, ex-US. It's an implantable unit placed in proximity to the tibial nerve. Those patients would get typically, 30 minutes of daily stimulation, and some of the responses have been pretty good in some of the trials, and there's actually published data as well that I have not included here. Bioness is this company, again, had an opportunity, but the company is not going forth, so we don't have any more information, or that won't be widely available. So, again, I'll just kind of highlight this last slide for me. The tibial nerve space is probably the area where we're seeing most of the development going on in the implantable tibial nerve space for some of the limitations that I highlighted before, and that's specifically the posterior tibial nerve stimulation. Works, but you had to keep coming in every week. Continual therapy and maintenance and so forth that we're not seeing with these implantable devices. So that might be the next frontier. I think we'll all have to, as practitioners, think about how we, counsel our patients. Are we going to have them come in periodically, or just going to go right to an implantable device? Am I going to go implantable in the sacral area, or am I going to just, not do any of those and go with the thing like an onabotulinumtoxinA with different mechanisms of action? So again, we're kind of in a real open frontier coming soon, and at least it's exciting to see that there's definitely different opportunities that'll be coming up in the very near future. KK, did you want to take it from here, or I'm happy to continue?
Yeah, no worries. Yeah, this is sort of the summary slide. Maybe we can switch out a little bit here.
I will stop my share.
Let's see here. It says can't. Okay, so The reason why I wanted to take it back is because I crossed this out, and that's the only reason why I took it back. The MRI compatibility and not for neurogenic bladder, that used to be the case. And I want to really emphasize the fact that that is no longer in the con category or con column for sacral nerve stimulation, because we now have MRI compatibility for full body MRIs. So if you really look at all of these things, I mean, we sort of divided it up. It was a little bit contrived because we wanted to cover all of these things, but I think it gives hopefully a little picture of the different clinical scenarios that we run into rather commonly, and in which patients, which therapy might be better. The lines have blurred a little bit with MRI compatibility, but if you look at this, there's pros and cons to everything, as there is with everything, right? So for neuromodulation at the sacrum, the battery life is anywhere from 7 to 15 years, depending on whether you use the rechargeable or non-rechargeable. Really, you don't have a big risk of retention like you do with Botox. And it has global effects on the pelvic floor. So if you've got dual incontinence, I think sacral neuromodulation is an excellent choice. The cons are, of course, you've got a device implanted in your body. There's potential complications, including, malfunction of the device or migration or infection, that sort of thing. We do it in a 2-stage fashion. I think that can actually be a con as well. I mean, a pro as well as a con, because they get to take it for their test drive, right? As far as Botox is concerned, the nice thing about Botox, a pro, is that it's done in the office, or it can be done in the office setting. The patients can drive themselves. It's remarkably well tolerated, and there's nothing implanted in their body. So I think that that's a really nice thing. The cons, it has to be done every 6 months or so, approximately. That might be a pro too for some people who say, I just want 1 day of relief, and 6 months is a godsend. There is a risk of retention, albeit low, very low, maybe 5%, a little bit less than that, maybe. Risk of UTIs. And then again, the durability really it depends on if your glass half full, half empty. PTNS, I think, has its role, as Dr. Savada just covered. There are nice things on the horizon where you won't have to come into the office every week for 12 weeks and then monthly thereafter. That's, I think, the biggest con for this technique. Things implanted right now, it's local anesthetic, or if that, in the office for the stuff on the horizon, but all in all, very well tolerated. So pros and cons of everything. I think at the end of the day, there's successful options that exist, and we just have to know the tricks. We have to know that they're there. They're very doable. Practice helps. So we would encourage you to, get through the learning curve, which isn't really that long. I mean, all in all, there's a lot more tips and tricks that we didn't have before, so that can really guide us. I think with everything, we all want to keep learning and keep innovating and keep, abreast of things. So as the techniques improve and the technology improves, so must we. So I think that I would really encourage any of you who haven't undertaken these things to, lean on any of us at any time, and we can help you get through that learning curve, because we can really make a huge difference for our patients. So with that, we are very appreciative of your spending the morning with us, or the afternoon, or wherever you are, evening. But thank you for spending the time with us. We do have a post test that we would really appreciate you doing with us here. And then if there's any questions, we can try to circle back, but we do have to do the post test for the completion here. So I'm not going to read the questions again, but if you could please go ahead and try to answer.